Dr. Govind, thank you so much for joining. You know me, we have worked in the past and we discussed a lot about colorectal cancer, and you helped me to, especially my friends, if they have any kind of a colorectal related or GI related problems per se, you're the first doctor who will come to my mind, and I'll ask my friends to visit you. Reason is that kind of a trust I have for the expertise that I was able to see, as well as the discussion that we had regarding multiple clinical conditions in the past. Okay, so for that, I'm really happy today to discuss with you, especially about the colon cancer. Now, I'll quickly talk about the platform that we are speaking to. So, this is our new initiative where we are trying to connect the knowledge gap between the industry, doctors, and people. And colorectal cancer is so important in India now. So, first thing I thought that I should discuss with you, and thank you so much to take out the time. And how are you doing?
Good. Thank you for all that you said, and it's good to be back speaking to you. And it was always a pleasure working with you. So I think colorectal cancer and how we can actually take a proactive step and prevent it rather than being more reactive with our treatment.
Correct. So I have seen, for normal people, it's very difficult to understand the super specialization, meaning of the super specialization. So, if you can help me break down what all you have studied to uh, be the right person for me to talk about the colorectal cancer. So, you have done your MBBS, your master's, and then your super specialization into the colorectal surgery.
Yeah, so I took a little bit of a different route to my education. I left India when I was 12 and I did my undergraduate in economics and biology, then went to medical school at Mount Sinai, and then went to do my surgical training at Cornell University. Both Mount Sinai and Cornell were very strong with colorectal diseases. And then I ended up doing a colorectal fellowship. In the US, they have a colorectal board. So they ended up doing a colorectal fellowship at Washington University in St. Louis, and then came back to work at Cornell. Cornell's program also worked closely with Memorial Sloan Kettering, so my exposure to cancer and its treatment was always very robust in my education. But I just want to backtrack a second because in the midst of all the super specialization, I think at the heart of it you end up forgetting that you are the patient's doctor, right? So you say, well, and I think this happens a lot, especially with patients day in and day out, because we are trying to get through our day, and you say, well, no, I'm a super specialist, I deal with only the GI issues, and sometimes we don't have the knowledge to deal with it, but oftentimes the compassion transcends all the subspecialties, so I think it's important to keep in mind that we are a doctor first, which is always a general doctor. A doctor um, is somebody that you look at as a kind of a he's a guide, or your that's how I see doctoring. I see doctoring not in the paternalistic way, but he's kind of like you're going into this jungle where you have no idea what's happening, and your doctor is supposed to be your guardian angel taking you through that journey, right? And we each have our little areas that we understand really well, so that's how I see this. And I think cancer prevention, it almost becomes ingrained in you. The specialty that I work in, gastrointestinal surgery, there's a fair amount of cancer, and many of these cancers can be cured. What symptoms could be a tumor related or cancer related? I think that's important. They don't need to go into a panic. You don't need to say, "Oh, every stomach pain could be a cancer." But I think some understanding will help.
True. Now, if you look at the GI symptoms, I think every Indian or every human, this is the most common symptom everybody will talk about every day, right? Like either you wake up bloated or you wake up with acidity, or so very rarely there will be good days. So we usually talk on social media about bad hair day. Okay, but there hardly any good day where you will say that, okay, I have a good stomach day today or good tummy day. You always have these kind of symptoms. Why these GI symptoms are so common in our country, and are they, because they are so common, are they misleading?
That's a relevant question. I think that it's very, very common to have everybody at home almost will, they will have a good GI day, bad GI day. I think we're understanding a little bit more about how the gut works. The what It's not just the chemical and the physical aspect of the gut, but the biological aspect of the gut, which is the microbiome that determines your mood. It can affect your gut health. It can affect how well you feel. Do you feel bloated? Do you feel uncomfortable? We're understanding a little bit of that. Now, it's very common to have these little GI niggles, and I think it's a product of our, urbanization, and we're no longer dealing with things like cholera and typhoid, where there was serious malaise. So we've moved from there, and we're looking at more lifestyle diseases, which certainly affect, how your day-to-day life. And in some ways we are more cognizant of all these kind of changes because the bigger hurdles in life have been sorted out for the most part. Having said that, many of these symptoms, especially if they happen repeatedly, or there is some severity to it, or there are some telltale signs that we should talk about. If you have any of those, I think it's important to get it evaluated.
Okay. So, so what are the key symptoms of colorectal cancer?
So when you speak about colorectal cancer in particular, bleeding. Okay, in India there is no recommendation to have screening, but in the Western world, everybody over the age of 45 to 50 gets a scope done automatically. We don't wait for any symptoms. But in our part of the world, there is no official guideline. So bleeding with bowel movements is an important sign that you should get evaluated. That is not a symptom that I would ignore. Many a times in a young patient, it's from a fissure or a hemorrhoid, but it's best to get your doctor to evaluate it and tell you that it's that. Anybody who has bleeding over the age of say 30 to 35, I may be over aggressive, but I end up recommending a colonoscopy because it's better to be safe than find out later that you missed something. Change in bowel habits is very common, and especially when it's consistent. There may be one day where you have, and if the caliber of your stool changes and consistently becomes smaller, then you worry if there's some blockage. Okay, that's another symptom. Another common symptom that patient, not symptom, but sign that patients see us with is, low energy, anemia, low blood count, and that's because they're chronically losing blood from the tumor. Okay, constipation also needs to be evaluated. There are many causes for constipation, from simple things like your thyroid and lack of fiber and all of that. But there are more serious causes for constipation, like colorectal cancer. So if you have any of these, my recommendation would be to see a specialist. I don't think let them decide what you need, what test you need. But pretty much anybody over the age of say 40, 35 to 40, depending on my clinical suspicion, I would recommend a scope for those patients with these symptoms.
Got it. Now, though it is not the part of our screening program, but still people, those who are aware or those who have, enough resources to screen themselves. Okay, how frequently they should be doing this colonoscopy?
Well, I think that's difficult to say, because see, the screening guidelines are based on the prevalence of a certain cancer, right? Now, in India, across India, maybe the prevalence is a little bit lower than what we would say in the US or United Kingdom. We don't know. Even the pickup rate may be higher there. But certainly in urban India and in the parts of India where we are almost getting into a similar lifestyle as we do as they do in the other more advanced, more developed, not more advanced, but more developed countries. I think that nobody knows. Okay, and it would be incorrect for me to recommend a colonoscopy as a screening tool when our authorities and societies haven't yet come out with a strong recommendation. But I say that if you have a relative who's had colorectal cancer, or you have any even a slight change in any of these parameters that we spoke about, I would recommend a colonoscopy. Certainly, there are some patients that come and say, no, we want to get scoped. I tell them, look, there is no guideline, and if you want it, if you lived in another country, they would have probably scoped you, right? So that's how I go about it. I think it's very difficult. We all practice evidence-based medicine, and we have some guideline that we follow, or some, we don't just decide that, this is my thing, I want to do it. So I think that, but first degree relatives, because I know a lot of patients that we have cured of colorectal cancer, but many of their own relatives, that is father, mother, uh, brother, sister, daughter, son, first degree relatives, they should get scoped. The recommendation is 10 years before the onset of the cancer for the primary patient, but the sooner the better, I would say.
Got it. You have explained me the symptoms that are there for which could be, colorectal cancer. How to identify these at a very, very early stage? How to catch the cancer at a very early stage?
So that's a little bit tough because these are very, aside from the bleeding, and even the bleeding, many patients experience a little bit of bleeding on the toilet paper when you clean yourself. So when it's persistent, you should go seek attention. And I think a lot of us know what is the good day, bad day, and usually this pushes you off the radar completely, right?
Mhm.
Now, the tumor has to be big enough to cause a blockage, and one would argue that then you waited too long. And the tumor should also ulcerate enough for it to bleed, and then one would argue like we should have waited too long. So I think with many of the now, for example, the ultrasounds that are done as normal corporate health checks are not recommended by any society, right? They're just done, right? So many a times there you may pick up some colon thickening, or although that's not a recommended guideline, it's done commonly, and we are quite quick to kind of recommend a colonoscopy even if there is some minor issue seen on the ultrasound.
So patients, those who are usually for these generic symptoms, like if they have bleeding PR once in a while, or for constipation, they reach out to their general physicians. And usually, we suggest general physicians, we suggest about dietary habit changes. Sometimes they give some medications. At what stage general physicians should not miss, and they should not miss any, or delay, and then refer the patient to the super specialty center, so that we are diagnosing cancer at early stage.
Well, first of all, I would recommend and urge all the general physicians at all ages of patients to at least once a year examine the anus, right? You should do a digital rectal exam, because you can diagnose things then and there. And if you have the facility for a proctoscope, a simple one, doesn't cost much. I think even that helps a lot. So I think that your basic evaluation should be there. You should examine the patient, do a digital exam, and have a low threshold. You don't even need to send the patient to a specialist. If your suspicion is high enough, just send them for a colonoscopy, because many of the clinicians will schedule colonoscopies as long as the patient comes with a prescription from their primary doctor. But yeah, and if it's beyond their kind of, not expertise, but beyond their kind of scope, then I would say refer early rather than later.
So, what is that one diagnostic, investigation that you do to confirm the diagnosis of the
So
cancer?
yeah, if on colonoscopy we find if it's a polyp, which is a precancerous lesion, the colonoscopist can usually remove it with the colonoscope. And as long as it's an early polyp and there's no invasive cancer in it, the patient doesn't need anything else. So this message should go out loud and clear to the clinicians, the patients, etc. If you have a polyp, you have a colonoscopy, they take out your polyp, you've avoided surgery altogether, and you've almost cured yourself because the cancer doesn't develop, right? That polyp is sent for histopathology, right? So there's the lab histopathology. So the lab processes it and tells us whether it's a precancerous lesion or a cancerous lesion, if there's invasion, if it's a villus adenoma. Or, I don't want to get into the scientific jargon of it, but if it's a lesion that they're not able to remove, or they feel it's a cancer, then they do what's called a biopsy. Then it tells us what the lesion is, and then we do what's called an extent of disease workup. So that tells us, then once we've diagnosed the cancer, then we have a certain steps that we take to then plan the treatment and first assess how extensive the tumor is and then plan the treatment.
Okay. And usually, after the diagnosis, within how many days patient needs to, if the surgery is suggested, within how many days they should go for the surgery?
Yeah. So first off, let me just backtrack and tell you. Once the biopsy confirms, the standard of care would be to get a contrast enhanced CT, and most people now are doing a chest, abdomen, pelvis CT. That tells us whether the cancer is restricted to the colon or it has spread or metastasized to other organs, maybe the liver, the lungs, whatever, and that helps us plan the treatment. If it has spread, then the role of surgery needs to be evaluated, and whether or not surgery is going to help the patient, we need to think about. Now, many a times in colorectal cancer, even if the tumor has spread to the lung and the liver or the peritoneum, which is the lining of the cavity, we have ways and we have modern tools like HIPEC, like liver resection and lung resection, which can be done safely. And we have patients who have survived after going through these multiple resections. Okay. Now, let me start talking first about the patient who has nothing but the cancer in the colon, right? When it's limit, and now I'm speaking about colon cancer, not rectal cancer. When it's limited to the colon, for the most part, again, I'm not going to get into all the latest trials that have looked at chemo first and all that. But for the most part, patients undergo surgery first. We do it with a minimally invasive technique like laparoscopy, robotic, whatever, and the patient is usually in the hospital for 3 to 4 days. Usually, we can avoid a bag as long as there's no blockage or dilated bowel, and the bowel is healthy, and they go back to their lifestyle relatively quickly. Rectal cancer is a whole other ballgame. Rectal cancer requires a multi-team approach. You need the radiologist, you need the radiation oncologist, you need the medical oncologist, and you need the surgeon to sit down and plan the treatment. Because what sequence you take for radiation, chemotherapy, and surgery makes a lot of difference. And that is best done in what's called a MDT, which is a multidisciplinary tumor board. Okay, so that is done. It's actually done for all cancers at our center, but it's very important to do it for treatment planning of any rectal cancer. Early rectal cancers, we still go ahead with surgery first. The more advanced rectal cancers, we may give some combination of chemo and radiation, and then do surgery, and then give more chemo. Sometimes give all the chemo up front. So there are many different paradigms, and I don't think we should go into that for this audience. Um, the patients that have the lesion has spread to the lung or the liver, many a times we do combined resections, meaning we take out a part of the liver tumor, which is actually the colorectal cancer that has gone to the liver, and we remove the colon separately or at the same time, depending on how extensive the surgery needs to be and how um, you know um, fit the patient is. So I think this is another important message that should go out to a lot of the clinicians and the patients listening to this talk. Unlike many other cancers, with colorectal cancer, if you get your CT scan as a general practitioner and you find that the lesions are progressed from the colon to the liver, don't write off the patient. Don't tell them, look, your cancer is advanced. We can't do anything for you. Don't do that. So if the patient has lesions in the liver and in addition to the colon or in the lung, please do not write off the patient and say, what, your cancer is spread everywhere, we can't cure you. It's not true. Colorectal cancer can be cured even when it has gone beyond the colon, and it needs to be done in selective cases. I'm not telling you that every patient can be cured, but that decision needs to be taken by an experienced team of doctors who are used to seeing these patients.
True. And I think that's where there is a importance of advanced tertiary care centers. I always like to talk openly about it, that selecting the right center for your treatment is very important. So it's the whole team that is required, and to take multidisciplinary approach, and that's why the importance of super specialty tertiary care quaternary care centers is very much key, especially in the cancer treatment.
Yeah.
Okay, so, and I was not much aware about that metastasized cancer also, not all the cases, but where in few cases there we still have hope. for the cure. Now, once the patient, is managed with the surgery and I don't want to get into the details of chemo and radio and how the whole treatment or targeted therapy or immunotherapy that we give nowadays. That is very much, I think, case to case basis. Like it is very much individually. Doctors, they plan with the tumor board and discussing the case. It's a long process that is involved into how the patient is treated. So let's talk about life after the procedure,
Yeah.
because that one part I don't want to discuss in this forum.
Sure.
That once the patient is back, now I have seen patients with colorectal cancer, post surgery, and let's talk about the quality of life. How they are supposed to manage their day to day life? Is it very normal for them, or do they have to take any precautions, or what's your experience, and what do you suggest?
Yeah, so the majority of patients we can get through the surgery without a stoma bag or an external bag. Okay, so once they recover, the first 4 to 6 weeks, we tell them not to lift anything heavy. But aside from that, we want them to go back to their life. We want them to pick up their job wherever they left, their home responsibilities, or whatever their hobbies. We want them to be back. In fact, I find it far easier to treat a patient who is waiting to get back to their lifestyle than one that is hesitant to get back. Okay. So our goal is always to get them back to their old lifestyle. If they have a stoma, which is a external bag where the stool collects, many a times it's temporary. It's very rarely permanent now. There are some situations where it is. If they have that, we have an entire um, repertoire of people who will kind of help teach them how to bathe with it, teach them how to go out, socialize, go to the temple, go to a wedding, uh, you know and intimacy, that teach them how they can be intimate with their partner with a stoma bag. So I think there is a good amount of knowledge that is developed around that. And certainly stoma is life changing, but it can also be life giving, right? Because it's given you back your life, and it's usually temporary. So then they go through the phase where we have the second surgery and we close the stoma. And then for the most part, they're back to their life. The one big difference that some patients may see is the pattern of their bowel movements, because especially if we remove the rectum, the compacting mechanism of the rectum is it needs to be taken over by the colon. Right. So that may take some time. You may have more frequent bowel movements or clustering of bowel movements. That can happen. You may have some altered bowel movements. You may have some difficulty controlling bowel movements. You may, if you have had rectal cancer surgery. Um, the other thing that could happen in rectal cancer surgery is that, especially for a male, their sexual satisfaction and ability to enjoy, have an erection, etc., may be difficult because the nerves are very close. With the advent of laparoscopy and robotics and all the advances, we're able to preserve the nerves very well. And so there are fewer and fewer patients who experience them, but that's one of the things that may look up. And of course, the urinary nerves are also there, so the pattern of urination may change. But I think from where we were to where we are now historically, uh, we're able to give patients, a lifestyle that has a good amount of quality, and a lifestyle that they can enjoy. So I don't think we ever look at a situation where we say, okay, you had surgery, now go home and just be at home. We don't want you to. So personally, I never take that approach, because for me, if I see a runner, if I see a photographer, I see a healthcare professional, I see a grandma, uh, who they are to me, the whole point of putting them through the treatment is to get them back to where they are. So I don't restrict their lifestyle to say, don't do this, don't do that, don't walk outside, don't. No, because that the whole point of getting them through surgery is to give their life, give them the lives that they've lived and enjoyed back, right? So that has always been my focus.
And you talked about like grandma and athletes or probably photographer. Was the youngest patient that you have treated? And
With colorectal cancer,
yes.
yeah, colorectal cancer, 18-year-old. So 18-year-old who found out she had colorectal cancer. right after she was pregnant and delivered her baby. And that's actually unfortunate because she had a genetic predisposition for developing colorectal cancers, and it was almost guaranteed that she would have developed colorectal cancer in her lifetime. For that, we would have done a surgery called a total proctocolectomy with a ileoanal pouch, wherein we remove the entire colon and rectum and we create a pouch so that they can use the pouch to store their stool. Okay, so unfortunately, for multiple reasons, she didn't undergo that surgery. So one of the polyps grew into a cancer.
So even as young as 18.
Yeah, but she had a very strong family history, right? And she again, I don't want people to listen to this and worry about colorectal cancer. It is rare, but since you asked me what is the youngest, 18-year-old.
Yes,
Yeah.
correct. And speaking about the genetic predisposition or hereditary factor or the history, family history, who are the people, those who should, get themselves screened? And what screening do you suggest to the family? What the diagnosis
Well,
always?
that's a very complex question. The simple answer to that is if you have any, so the common ones are polyposis syndromes, wherein people inherently have polyps in their colon and rectum, and then the probability is that one of them will become cancer. That's what the young lady had that I took care of. There are also syndromes where you have, uh, you know, it's called HNPCC, or where there is a field defect, but you may not necessarily develop a polyp. Okay, so many of these polyposis families, they know that my uncle had it, my dad had it. So if that situation arises, you should get a scope done, and now you can get genetic testing done. You can get Uh, multiple other IHC that it's beyond the scope of this talk, but the colonoscopy is easy to get. It's quite safe, easy to get, and you might as well get it. But the genetic testing, etc., you need to see a specialist, and they need to look at what the family member had. Do they have a pattern? It's not just based on the genetic test, but it depends on the pattern of inheritance. Okay, most cancers, if not all cancers, have some element of a predisposed genetic kind of risk that you carry and an environmental factor. And there's some combination of those two, right? So in some of these, it's more robust. The genetic side is more robust.
And like of course, after discussing even the treatment and follow up, I'm asking this question because I wanted people to understand the whole, what goes through when it is about the colorectal cancer, why it is happening, what are the risk factors, excluding the genetics that anything in the lifestyle that we are doing that we
Well,
get.
at a population level, well, let me track back. Fiber, we didn't talk about fiber. Fiber has been clearly shown to help patients with colorectal cancer, prevent colorectal cancer. It actually is the first line of treatment for a lot of other anorectal and colorectal conditions, from diverticulitis to hemorrhoids. And here I'm going to take a minute, and this message should go out to your audience wide and clear, right? This should be actually highlighted to them. There are so many newer, unnecessary kind of treatments that are being labeled as laser and painless, bloodless. Don't go for marketing, right? You have to practice evidence-based medicine. Half the time, you don't need any procedure for your hemorrhoids. I'm a colorectal surgeon, probably the only board-certified colorectal surgeon in Bangalore, and most hemorrhoids can be treated with fiber. You don't need to operate on them. You don't need to do a procedure on them. Of course, if you have a patient sitting in front of you and you say, "Yeah, I can do this," or "I can, put a band on it," the patient is going to say, "Okay, what should I do?" They don't know. So, the, fiber first line treatment should always be fiber for hemorrhoids. And this is a slightly side topic.
Yes, so how to change your lifestyle, what are the causes?
Yeah, at a population level, red meat has been shown to, um, but not. It's not a direct effect. Like I eat red meat today, tomorrow I'm going to get cornea. It's not like that. Smoking is definitely a risk factor. It's not specifically. There's many cancers that it's linked to. Um, uh, Alcohol is again controversial, especially beyond a point. It may think now your fitness level is something in your hands. So I would say smoking is a definite no-no. Alcohol, do it in moderation if you're going to do it. Um, And fitness is something in your hands. It's very clear that if you're obese or you're overweight or you're not fit, then your risk of cancer goes up. So these are things that patients can actually do themselves and eat fiber, stay fit. Uh, you know, um, don't be excessive with any of your vices. You know, and if you have some telltale sign that's popping up, don't ignore it. I mean, those are really that's really the crux of trying to prevent colorectal cancer and treat it early.
Coming back to the treatment part of it, we talked about how much of the follow up that is there, and what's the lifestyle after the surgery. Very simple question in India, like we have so much of out of pocket expenses. So all these procedures that we talked about, is it covered under medical insurance, or something that is not covered?
Well, the outpatient procedures are not always covered by the present insurance systems. That means diagnostic procedures like colonoscopy, if it's an outpatient procedure, then you don't cover it. Most of the cancer surgeries and chemotherapy, they're all covered by insurance. Of course, it depends on which insurance you have and what their, you know, if you pick up the insurance after you got the diagnosis, they're not going to cover it, obviously. Um, but outpatient procedures are not covered as of now. But I think there are some newer companies which have kind of a different view on how insurance should work, which are covering certain outpatient costs and procedures. I think that's still in its infancy in India. But in the US, colonoscopy was covered. In the UK, of course, it's a NHS, so everybody gets covered. But you may wait for 6 months for your colonoscopy.
So, I don't want to talk more about the advancement of the treatment and procedure related thing. Any message you want to give it to people, normal population, regarding the colorectal cancer, whether it's a preventive aspect or early detection or treatment aspect of
No,
it?
I think we've covered everything. I think you like a few more minutes back we spoke about fiber, fitness, vices keep keep under moderation, which would be alcohol and smoking shouldn't happen really. Um, if you have some telltale sign like constipation, bleeding, change in bowel habits, change in bowel caliber, you're losing weight without a reason, your energy levels are low, don't ignore it beyond a point. And if you are somebody who uh, is related to somebody who has had or recovered or succumbed to colorectal cancer, then your threshold to get a colonoscopy should be much lower and you should just go get it.
I think for normal population, that's all I
Yeah,
wanted to
yeah.
ask about preventive aspects and mostly the uh, you know top level care part of the colorectal cancer. Thank you so much for your time.
Yeah, thank you.